Welcome to G-Fun Facts Online. Today we're venturing deep inside the most complex organ we know, the human brain. But we're not looking at neurons or memories. We're exploring the intricate network of blood vessels that keep it running, and a silent, potentially deadly threat that can form within them. This threat is a brain aneurysm, a bulge in a blood vessel that can exist for years without a single symptom, only to announce itself with a sudden, catastrophic rupture. Understanding these vascular time bombs is a journey into the mechanics of blood flow, genetics, and the very architecture of our arteries. So what exactly is a brain aneurysm? Imagine a worn, thin patch on a tire's inner tube. Now imagine that patch is on the wall of an artery deep inside your brain. The constant pressure of blood pulsing through the artery, millions of times a year, can cause this weakened spot to bulge outwards, forming a small blood-filled sac. This is a cerebral or intracranial aneurysm. While many of these remain small and harmless, the danger is that they can burst. When they do, blood spills into the space surrounding the brain. This event is a type of stroke called a subarachnoid hemorrhage, and it is a true medical emergency. Just how common are they? It's estimated that about 3.2% of the world's population has an unruptured brain aneurysm. That means in the United States alone, nearly 7 million people are living with one right now, most completely unaware. The good news is that ruptures are much rarer, happening to about 30,000 Americans each year. But when they do happen, they are often devastating, typically striking people around the age of 50. Now, not all aneurysms are created equal. They're classified by their shape and size, which helps doctors determine the risk. The most common type is the saccular aneurysm, often called a berry aneurysm. If you picture a berry hanging from a small stem on a vine, that's a perfect visual. The berry is the blood-filled sac, and the stem is where it connects to the artery. These typically form at the forks or branches in the major arteries at the base of the brain, and they are the type most likely to rupture. Then you have fusiform aneurysms. Instead of a sac bulging out from one side, the entire circumference of the artery wall balloons out, creating a spindle-like shape. Finally, there's a rare type called a mycotic aneurysm, which isn't caused by a fungus, as the name might suggest, but by an infection in the arterial wall itself that weakens it and causes it to bulge. Aneurysms are also classified by size, from small ones less than 7 millimeters, all the way up to giant aneurysms over 25 millimeters. You might think the bigger it is, the more likely it is to rupture, and while larger ones do have a greater tendency to burst, the surprising fact is that most ruptured aneurysms are actually on the smaller side, less than 10 millimeters in diameter. The most insidious thing about brain aneurysms is their silence. Most produce no symptoms at all. They are often found by accident when someone gets a brain scan for a completely different reason, like a concussion or persistent headaches. However, if an unruptured aneurysm grows large enough, it can start pressing on nearby nerves or brain tissue. When this happens, symptoms can appear. This might be a persistent pain above and behind one eye, a pupil that suddenly becomes dilated and stays that way, changes in vision or seeing double, or numbness on one side of the face. In some cases, a small amount of blood might leak from the aneurysm, an event called a sentinel bleed. This can cause a sudden, very severe headache that serves as a warning sign, days or even weeks before a potential major rupture. When a full rupture happens, the primary symptom is unmistakable and terrifying. It's often described by patients as the worst headache of my life, or a thunderclap headache, a pain that is both instantaneous and excruciatingly severe. This is often accompanied by nausea, a stiff neck, extreme sensitivity to light, confusion, and in many cases, loss of consciousness. So if doctors suspect an aneurysm, how do they find it? They turn to a suite of sophisticated imaging technologies. The first line of defense is usually a computed tomography, or CT scan. This is a rapid X-ray based test that can quickly show if there is bleeding inside the brain. To get a better look at the blood vessels themselves, a CT angiogram or CTA is used. For this, a contrast dye is injected into the bloodstream, which lights up the arteries on the scan, creating detailed 3D maps that can reveal an aneurysm's exact size, location, and shape. Another powerful tool is magnetic resonance imaging, or MRI. Using strong magnetic fields and radio waves, an MRI provides incredibly detailed pictures of the brain's soft tissues. A special type of MRI, a magnetic resonance angiogram, or MRA, is specifically designed to visualize blood vessels. But the gold standard for diagnosis is a procedure called cerebral angiography. This is an invasive test, but it provides the most detailed images possible. A neuroradiologist inserts a thin, flexible tube called a catheter into an artery, usually in the groin or wrist, and skillfully guides it all the way up through the body's vascular network into the arteries of the brain. Once in position, a contrast dye is injected directly into the brain's arteries, and a series of high-speed X-rays capture the blood flow in real time. This reveals the precise anatomy of the aneurysm, which is critical for planning treatment. In some cases, if a rupture is suspected but a CT scan doesn't show any blood, a doctor might perform a lumbar puncture or spinal tap to check the cerebrospinal fluid for red blood cells, a telltale sign of a bleed. This brings us to the core question: why do these weak spots form in the first place? The science of aneurysm formation is a fascinating story happening at the intersection of blood flow physics and cellular biology. The arteries in our brain aren't rigid pipes. They are living, dynamic tissues. At the base of the brain is a critical structure called the circle of Willis, a ring of arteries that acts as a traffic circle for blood distribution. This area has numerous branches and forks. At these intersections, the blood doesn't flow smoothly. It becomes turbulent, creating areas of high pressure and force, known as hemodynamic stress. It's believed that this constant pulsating stress on the artery wall, especially at these branching points, is the initial trigger. At the microscopic level, this mechanical stress kicks off a chronic inflammatory response. It starts with the endothelium, the single layer of cells lining the inside of all our blood vessels. This layer gets damaged by the high-pressure flow. This damage, called endothelial dysfunction, is like a crack in the artery's armor. It triggers the cells to send out distress signals, which call in the body's first responders, immune cells, particularly macrophages. These macrophages infiltrate the artery wall at the site of injury. Once there, they release a cocktail of powerful chemicals, including enzymes called matrix metalloproteinases, or MMPs. The strength of the artery wall comes from a scaffold of proteins called the extracellular matrix, made of collagen and elastin. The MMPs released by the inflammatory cells begin to digest and break down this protein scaffold. At the same time, the inflammatory environment causes the smooth muscle cells within the artery wall to die off through a process of programmed cell death called apoptosis. These muscle cells are vital. They repair the wall and produce new collagen and elastin. So you have a destructive process, the breakdown of the matrix, happening at the same time as the loss of the cells responsible for repair. This deadly combination leads to a progressive thinning and weakening of the artery wall. Eventually, that spot can no longer withstand the relentless pressure of the blood flow, and it begins to bulge outward, forming an aneurysm. So we have this ticking time bomb. What determines whether it goes off? The study of why an aneurysm ruptures is just as complex as why it forms. Again, hemodynamics plays a central role. Researchers now use powerful computer simulations called computational fluid dynamics, or CFD, to create detailed models of blood flow inside a specific patient's aneurysm. These models have revealed a paradox. Both very high and very low forces can lead to rupture. High wall shear stress, which is the frictional force of the blood flowing along the aneurysm wall, can drive the growth and rupture of smaller aneurysms through direct mechanical failure. Conversely, in larger, more complex aneurysms, areas of low, stagnant blood flow can promote more inflammation and the formation of blood clots, which further destabilize the aneurysm wall, making it more prone to tearing. The aneurysm's specific shape, its size, and even the angle at which it juts out from the parent artery all influence these forces and contribute to the risk. Beyond the physics, there are well-known risk factors. Larger aneurysms and those that are observed to be growing on follow-up scans are at higher risk. Location matters too. Aneurysms in the arteries at the back of the brain are more likely to rupture. And then there are lifestyle and genetic factors. Uncontrolled high blood pressure puts constant, excess stress on the weakened wall. Smoking is a major risk factor, as the chemicals in tobacco smoke are known to accelerate the inflammatory processes that weaken the artery wall. A family history of aneurysms also significantly increases one's personal risk, pointing to a genetic predisposition. When an aneurysm does rupture, the consequences can be catastrophic. The resulting subarachnoid hemorrhage is a devastating event. Nearly a quarter of people die within the first 24 hours, and about half will die within 3 months. For those who survive, the journey is just beginning. The initial bleed sets off a cascade of life-threatening complications. The biggest immediate threat is rebleeding from the unsecured aneurysm, which carries a mortality rate approaching 70%. In the days following the rupture, the brain can react to the blood by causing the arteries to dangerously narrow and spasm, a condition called vasospasm. This can cut off blood supply to parts of the brain, causing a secondary stroke and more brain damage. The blood can also clog the normal drainage pathways for cerebrospinal fluid, causing it to build up in a condition called hydrocephalus, which increases pressure on the brain. The event can also throw the body's delicate sodium balance into disarray and put immense stress on the heart, sometimes leading to cardiac failure. Given the stakes, how do doctors defuse these time bombs? For unruptured aneurysms, the decision to treat is a careful balancing act, weighing the risks of the procedure against the estimated risk of rupture. Small, stable aneurysms might just be monitored with regular scans. But for a ruptured aneurysm, immediate treatment is essential to prevent a deadly rebleed. There are 2 main surgical strategies. The first is surgical clipping. This is traditional open brain surgery. A neurosurgeon removes a small piece of the skull to access the brain, and using a powerful microscope, carefully navigates to the aneurysm. They then place a tiny metal clip, which looks like a miniature clothespin, across the neck of the aneurysm where it connects to the artery. This clip seals off the aneurysm, preventing any more blood from entering it. It's a highly effective permanent fix, but it is also highly invasive, with a recovery time of 4 to 6 weeks and the inherent risks of open brain surgery. The second and increasingly common approach is endovascular coiling. This is a minimally invasive procedure performed from inside the blood vessels. Instead of opening the skull, a neurosurgeon or neuroradiologist inserts a catheter into an artery in the groin or wrist and guides it all the way to the aneurysm in the brain. Through this catheter, they then feed tiny soft platinum coils directly into the aneurysm sac. They continue packing coils in until the aneurysm is densely filled. This disrupts the blood flow and induces a clot to form, which effectively seals the aneurysm off from the inside. Recovery is much faster than with clipping. For more complex aneurysms, this procedure might be combined with other technologies. For instance, a small mesh tube called a stent can be placed across the aneurysm's neck to help hold the coils in place. An even more advanced technology is the flow diverter. This is a specialized, dense mesh stent that is placed in the parent artery across the neck of the aneurysm. It doesn't block the aneurysm directly. Instead, it redirects or diverts the majority of blood flow past the opening. With blood flow and pressure inside the sac dramatically reduced, the aneurysm stagnates, clots, and over months shrinks and heals over. This has revolutionized the treatment of very large or awkwardly shaped aneurysms that were once considered untreatable. Looking to the future, the field of aneurysm research is moving incredibly fast. Large-scale genetic studies are identifying specific gene variants that predispose people to forming aneurysms, which could one day lead to targeted screening for high-risk individuals. Scientists are also exploring medical therapies, investigating whether drugs like statins or even aspirin could be used to quell the inflammation in the artery wall, potentially stabilizing or even shrinking small aneurysms and preventing the need for surgery. The computer modeling of blood flow is becoming more and more sophisticated, allowing for better, more personalized risk predictions to help decide which unruptured aneurysms truly need treatment. And the technology for endovascular repair continues to improve, with new generations of coils, stents, and flow diverters, making the procedures safer and more effective for even the most complex cases. The journey to conquer the silent threat of brain aneurysms is a testament to the power of scientific and medical progress. By delving into the intricate vascular science that governs their formation and rupture, and by inventing ever more innovative tools to diagnose and treat them, we are steadily changing the narrative. What was once a hidden and often fatal condition is becoming a detectable and manageable one, with the ultimate goal of turning this silent threat into a silenced one. Thank you for joining us on Fun Facts Online.